Yeah, thank you, Dr. Kavanaugh, and thank you so much. My name is Andrew Wang, and I'm not a physician by training, but a public health scientist. And I'm really glad to have the opportunity to present Dr. Ted Pak, Theodore Pak. I'm a member of the People CEC, and I've worked very closely with Dr. Pak over the last few years. And we published an opinion piece in CNN, which I just put in the chat here regarding the importance of hospital-acquired COVID infections and tracking them and the importance of masking. So with that, Dr. Pak is an infectious disease physician scientist at Massachusetts General Hospital and the Department of Population Medicine at Harvard Medical School, conducting research on how artificial intelligence methods can enhance the analysis of electronic health records for patients with high impact infectious diseases. His work is very important, especially regarding the ongoing COVID pandemic, and we look forward to hearing the findings of his results that were published in JAMA Network Open. And thank you so much for having me to introduce him today.
Thanks, Dr. Wang and Dr. Kavanaugh, for inviting me. Can folks hear me okay? Just a thumbs up. Okay,
Yes.
excellent. Thank you. So as mentioned, I'm talking today about a recent study we published, which compared hospital onset respiratory viral infections with changes in policies across 10 New England hospitals with regard to masking and testing. And I've listed my co-authors on the study here. As a disclosure, I do have a software company that I founded some years ago. It makes apps for clinical education mostly, but none are specifically about COVID-19 or infection control. As just one other disclaimer, although I'm an employee of Mass General Brigham, I'm not a policymaker there, and these are my personal opinions and not those of the institution. So the question of the study was, how is the risk of these three viruses, COVID, influenza, and RSV, affected by hospital masking and testing policies, specifically with regard to infections that are occurring in hospitals? And just to set the scene for you, I started my medicine residency in 2019 in Mass General. So just 8 or 9 months into my residency, this kind of became my life. I probably saw more COVID patients than any other kind of patient during my medicine residency. And this is the kind of PPE we were wearing for often the majority of patients that we saw on our floors. Around the beginning of the pandemic, many new infection control interventions were implemented. A lot of them are universal interventions because we simply didn't know anything about this virus at the time, and it was felt that we needed to protect everybody in the hospital given how highly contagious these COVID was as it arrived. These are just some the changes that you would see walking in the hospital, masks that all visitors and staff would wear. As was pointed out, these are surgical masks, not N95s. At the beginning of the pandemic, we even had N95 shortages, but I won't go into that. But yeah, this is just an example of the many changes that hospitals went through during this time. We also implemented testing for all patients. So before patients would come to any of the floors, they would have to undergo at least 2 nasal PCRs until they were considered ruled out for COVID. And those, as testing capacity ramped up over time, that was something that expanded more and more, such that we were testing patients serially in the hospital throughout their stay to ensure that they weren't getting COVID from other people either. And then there was a shift in 2023. And we saw this amongst leaders in infection control who started to write opinion pieces about these universal precautions and why they might not potentially be necessary. It's kind of surprising for me to see at the time, but for instance, the Society for Healthcare Epidemiology for America put out a press release saying that pre-admission COVID testing and essentially universal admission testing was no longer recommended. And then other similarly high impact editorials were released about universal masking and why that should also stop in hospitals. And there are a bunch of reasons that these editorials gave at that time. which included for testing that they were creating lots of false positives. They were creating lots of delays in care for patients that happen to test positive before their surgery and so on. And for masking, some complaints that were raised were physical discomfort, impediments to communication, and observations that people didn't always wear them correctly and had them, below their nose or whatever. The running through line, though, if you really look carefully at all these editorials, is that these interventions were viewed as costly. And was lots of messaging coming out from the federal government, as you may have remembered in early 2023, about the pandemic being over, in air quotes, and that public health emergency funding ended. And to really understand it, health systems at the time were using a lot of that funding on these universal interventions, and seeing that it was about to end in May 2023, I can't help but imagine that that had something to do with the reluctance to continue to do these things. There's also a general perception that COVID was becoming a more manageable disease, at least within the hospital, and we had, of course, vaccines by that point and antiviral treatments that were being used for cases, including hospital onset cases. And there are a lot of complaints that these precautions had never been measured for efficacy and whatnot. And that's part of the impetus for studies like this one that I'm showing you today. I was involved in various editorials that provided a counter narrative at the time, supporting the continuance of universal admission testing. And also my colleagues wrote about why masking actually is quite valuable. And we had lots of arguments that I still believe to this day. Respiratory virus infections in hospitals are more common than you think, and frankly underreported. And as Dr. Kavanaugh pointed out at the beginning of this meeting, there's very little good public surveillance data about it in the US. We routinely rely on other countries, sadly, to know about rates of this. And then always the argument comes up, well, does that really equate to our healthcare system here in the United States? But in the US, we have just very poor, if any, mandatory reporting mechanisms for these kinds of phenomena. COVID is really transmissible in the hospital. We had a cross-sectional study early in the pandemic that showed if you are admitted to the hospital and your roommate has COVID, unbeknownst to you, which happens because tests don't always turn positive promptly when these patients arrive and become infectious with sometimes few symptoms, there's a 20 to 40% risk of transmission actually in that scenario when you have an infected roommate and no precautions. Hospitals contain a very different mix of people than the general population, and I would argue this population is particularly vulnerable to COVID. We have cancer patients, transplant patients, people with no good immune reaction that they could generate against this virus. So I've seen devastating complications of COVID infections when they start in the hospital. And furthermore, we argued in these editorials that testing and masking are both relatively low cost compared to the many costs of developing COVID and the many harms of that infection during and after the patient being in the hospital. In particular, universal masking is extremely cheap on a per person basis. We're talking about cents, per staff or visitor per day. Just some numbers to get a sense of why Omicron, which a lot of headlines many years ago tried to describe as mild, is in fact far from that in the hospitalized population. Hospital onset cases of Omicron have a substantial crude mortality. And in a propensity matching analysis that we recently did in our own hospital system, that was published in Annals of Internal Medicine, we found that if you got Omicron in the hospital, you have a 60% higher risk of death compared to a comparable patient at the time that did not get Omicron. So it's not a benign infection to get in the hospital setting, because if you think about it, a lot of the time you're in the hospital for something else that is that would increase your risk of a COVID infection and poor outcomes. So this is something that I too think is underappreciated. There have been some small studies on how masking has associated with various changes in hospital onset COVID. The limitation with most of these studies is that they typically are about one hospital. And like I said, because we have such poor reporting mechanisms in the United States, it's hard to collect larger data sets for hospitals that would be convincing to our policymakers about this topic. Again, an impetus for doing this study. As far as testing goes, we put out our own study in 2023 that used this kind of natural experiment where the NHS in the United Kingdom decided to stop universal admission testing, and they happened to release pretty robust public data about hospital onset COVID, defining it as any COVID that starts 7 days into admission or later. And you can see that rates of hospital onset COVID jump immediately after they change this testing policy. Now, this engendered a lot of debate at the time where some folks thought this is all measurement bias because when you change your testing policy, you also change the ascertainment of each kind of case. And it's very difficult for us to go back and look more at these cases because obviously we're not in the UK and this is public health data that they release publicly. So we have no clinical information on each of these cases. So here's an example of that criticism. The level change could be expected if, even if there's no actual increase, those with persistent shedding are no longer captured as community onset cases, et cetera, et cetera. And you saw this in a lot of the reactions to that study and saying, well, we don't know based on that data still. So that brings us to this study. Mass General Brigham has more than 10 hospitals actually, but we use these particular hospitals for our data set. There's Mass General, there's Brigham, 2 academic centers. We have 7 community hospitals that are a little farther away. We also have an eye and ear hospital that we included. The benefit of using our own data for this hospital system is that now we're able to dig deeper in every single case. And we're able to ask some of the questions that people raised by looking at the actual history for each patient and seeing, was this actually a hospital onset infection? Is there really any case to be made about asymptomatic shedding and so on? This is a review of the policy changes that occurred in our healthcare system. You can see that shortly after the pandemic started in early 2020 here in the United States, we had implemented universal admission testing as well as universal masking. And as soon as there was enough capacity for this, which happened around Omicron, there was also a mandatory serial testing policy where every 5 days in the hospital, patients, regardless of symptoms, got a COVID test. That continued through about May 12, 2023, when all of it stopped. And then as cases picked up again in January 2024, every winter we have what you could call a winter respiratory viral season, right? Formerly known as flu season, but now it's a mix of viruses. And Mass General Brigham did re-implement masking for staff only. So we actually got a 4th period in our study to look at what changes when staff resume masking. Just to give you a sense of how much the policy change affects testing rates, this is what it looks like in terms of policy compliance before and after. So the gray bars here is the proportion of patients getting tested before they are admitted to the hospital or during their admission process. And then afterward, once this mandatory policy is stopped, there's a huge shift over to most patients not being tested because you could only be tested after that point if you actually had symptoms that prompted testing. I mentioned serial testing as well. So because we had that policy before the changeover to test patients every few days, there was a almost consistent 4 to 5 day interval between tests in those patients that also got a lot longer after we stopped our universal policies. So back to the question, when universal masking and testing policies changed, how did the risk of hospital onset COVID, flu, and RSV change? The method we used for this was a Poisson interrupted time series analysis. We defined hospital onset as first positive after 4 days into the admission. We also used the fact that some infection flags are cleared quickly because they realized the test was likely reflecting a very old infection that was well documented. So we used some criteria to try to filter out false positive cases. And our outcome variable was looking at how the rate of new hospital onset viruses change per the baseline of community onset cases. And I'll explain that a little more in a second. This is what the statistical model looked like. We had 4 sets of variables, one for each period of the study. We incorporated seasonality into our model because we recognize that certain aspects of policy implementation may change between, let's say, winter and summer. For instance, in the winter, during a period where clinicians have to recognize symptoms in order to order testing, there may be more awareness of respiratory viruses in the winter and greater propensity to test, for instance. So we tried to include that possibility in our model. So this is how we calculated our relative risks here, and then we used bootstraps to calculate confidence intervals. So I mentioned that we adjusted our data to a baseline of community onset cases. And the reason for that is we are trying to measure here how these policies change onward transmission within the hospital. We expect hospital onset cases to change relative to community onset cases. You can kind of see that actually in data from a large study in Germany. Every time there's a peak here in the gray bars, which is community onset cases, you have a corresponding increase in hospital onset cases as well. For each wave of the pandemic, the ratio between these peaks changes for each wave, but it's not particularly interesting to just say that hospital onset cases are increasing without regard for how much COVID there actually is in the community at that given time. So that's why community onset cases are included as an important variable in this model. So finally, to answer these questions of after testing policy changes, are you actually changing your ability to pick up community onset or hospital onset COVID? We did a chart review on 100 randomly selected cases, and we tried to look for evidence in the chart that somebody testing positive more than 4 days into their admission is actually having a new case of COVID that they caught in the hospital. And key questions are, was that test ordered because the patient is reporting new symptoms of COVID at that time in the admission? Did they report being exposed to a COVID positive person, or do we know that they were, for instance, a staff member or a roommate that tested positive? Did the test pick up a relatively larger amount of virus? We can use something called the PCR cycle threshold to infer that. And then we can also look at whether there was a prior negative test during the same admission, which builds more evidence that this is a new infection rather than a positive test from a old infection that the person is still shedding virus from, or viral RNA. So let's now go to the results here. When universal masking and universal admission testing policies changed, how did the risk of hospital onset viruses change? So first, we're just going to look at the top line results, and this is without any adjustment. You can see here that the ratio between hospital onset and community onset cases increases during Omicron. That's something that we can see across many different studies. Omicron is much more transmissible. In the healthcare setting, it was definitely more transmissible. And we see this jump from 2.9% to 7.6%, meaning that in this period, for instance, out of all the COVID cases that are admitted to the hospital, about 7 or 8% of these cases start after 4 days, indicating that they probably started in the hospital. After the masking and testing policy ended, we see this jump from 7.6 to 16%. And then when staff restart masking, it falls back down to 8%. So this is just the unadjusted data, and it already is suggestive that when you have no precautions, there's a higher ratio. So this is what that looks like, just the unadjusted data and looking at those confidence intervals that you can generate before you add any other variables into the model. If you break this down further, you will see why we decided to include all three viruses rather than just focusing on COVID. We really did want to keep this study as current as possible by going through the last winter respiratory virus season. And we had a much more even split between COVID, flu, and RSV in this last viral season. Influenza really came back relative to how it had been for the prior 2 to 3 years. So that's part of why we think in metrics going forward, really, we should be reporting all these viruses. There's plenty of data on how dangerous nosocomial flu and RSV are as well. And that's why we included them in this study. So here's what it looks like after you add some adjustment to the model for seasonality. So this is, you can start seeing the sort of sinusoidal pattern here, which accounts for that, as well as trends within each period. And using this model, we found a statistically significant jump in hospital onset cases after masking and testing ended, a 25% increase, and then a statistically significant decrease of 33% when staff restarted masking. And all this would suggest that masking and testing associates with lower rates of hospital onset COVID. So, excuse me, in this review of 100 random patients to see did the testing policy change our ability to accurately find cases of hospital onset COVID, in general, we found that these patients that we're finding with the 4-day criterion really look like genuine cases even after universal testing had ended. 89% are tested not because of some external reason, like they have to be discharged to a facility or they're getting a procedure. They're being tested for the most part because they're reporting COVID symptoms. About 4/5 of them have a fairly low cycle threshold on their COVID test. So this is not a small amount of virus that the swab is picking up. And then a good proportion of them also have a recent exposure. If you allow for any of these first three criteria, 97% of the patients are meeting one of them. We do have some limitations in this study that I should point out. This is not a trial. We don't have controls. This is one system in the United States that implemented a bunch of policies simultaneously and then de-implemented them and so on. There's going to be variability between each of the sites within the system as to how well they follow these policy changes. But we believe this is also the largest study, at least in the US, to look at this kind of issue. And we do have this very nice contrast in our study where there's a period of time where universal masking and testing have ended and then masking is resumed. So the fact that the outcome variable shifts in one direction and then back when masking is re-implemented is strongly suggestive to us that there is an association here between masking and lower hospital onset COVID rates. So in conclusion, we would just strongly say that universal masking and testing policies are valuable tools for healthcare systems to use to fight respiratory viruses. We particularly think that masking during respiratory viral seasons is valuable because, as in our study and all prior studies, hospital onset cases are very closely linked with community onset rates. There are higher community rates every winter, and I mean, we should continue to monitor this, obviously, but anytime there is higher community onset infection, we should really consider both of these interventions. And we believe that the data that we show here is supportive of the efficacy of both of these pieces of the infection control arsenal. I'd like to thank my mentors, particularly Mike Klompus and Chana Rhee, who work in hospital epi at Brigham, and of course my infectious diseases fellowship. And I'd love to hear all of your questions.